Bismillah Rahman Rahim. Today we are going to do the sickle cell specific complication. So we already know that the sickle cell, we have two type of things which we are concerned. Sickle cell carrier, or she is a sickle cell disease. But if she is a known case of sickle cell disease, then she will be having a more complications. So we have to know that there will be a complication, there will be acute complication, and there will be a chronic complication. Just we have to have a look. This will be the green one is the chronic complication, and the yellow one is the acute complication. So if just for us is the important is the acute one. Acute one is what? Acute chest syndrome, acute pain even, and then she can have a hepatopathy, and then gallstone. This is are not so much important. The important thing is that one septicemia, splenic dysfunction, and splenic sequestrations. And this bone marrow infarction and osteomyelitis, these are, and the stroke. For gynae point of view, we have to have only four things are important for us. These are the other things they can be important. They say that complication of the pregnancy, we have to know. But these things are important for the chronic and the acute one. But as if we will go for the pregnancy, see, what for us for most important thing is the sickle cell crisis and acute chest syndrome when she is pregnant. This is the most important one. And if she will be the pregnancy specific complication, if we will concern, they are dividing it, okay? They divided it in those sickle cell specific complication, pregnancy specific complications, and increased incidence of sickle cell. So if we will go, we already know sickle cell specific complication, what? Sickle cell crisis, acute chest syndrome. If we will go to the pregnancy specific complication, what it will be? Thromboembolism, urinary tract infection, spontaneous abortion, and proteinuric hypertension. And then there will be increased incidence of what? Antepartum hospitalization, because she will be in pain on and off, or other complications. So most of the time she will be hospitalized for many problems. Postpartum infection, increased risk of cesarean section. She can have a low birth weight baby, preterm birth, premature baby, and IUGR. These are the increased incidence. Here for us, the important thing too, sickle cell crisis and acute chest syndrome. This is the complication in the exam. And this is the top question, and this is the question they are going to ask it. Here we have other complications named, just I have to tell you. This we are going it, just we will tell the name. See, just we know it sickle cell crisis and acute chest syndromes. The other one is important, is what we call it here right now. We don't, here we have it. Here we have it, acute stroke. This is also important, but this is acute stroke. We have to know infarctive and hemorrhagic. This just, we have to know the name. They are not going to ask it what it is going to be happening. And then this is the most important one. Okay, the stroke is the other important thing. That's the 3/4 complication names we have to know. Now we are going to do this one. Our main one is that acute cell crisis and acute chest syndrome. These are the two ones. Okay, now first we will go for the acute cell crisis. See, any patient, how she will live. If she is presenting in pregnancy, this management should be implemented within 30 minutes of pain, because what is the meaning of this acute cell crisis? Within 30 minutes, we have to diagnose and we have to do the treatment. This is the plan. We have to make it. If she is less than 23 weeks, we have to go for the hematological team. They are the one who is going to manage her along with obstetrician. But if she is more than 23 weeks, she has to be admitted to the labor ward. And if she needed it, ventilation and other things are at that time. Right now we are talking what we have to do. Okay. We have to ensure that the hematologist and obstetrician team has to be there. Means what? We have to inform the MDD team. MDD team has to be there. Okay, we inform it. Then what we are going to do? This we have to do in a stepwise manner. And all these things you are going to get it, inshallah, this, I'm start recording now. There is a recording going on Zoom. So it will be on Telegram. Inshallah, after finishing, I will put on Telegram. Okay, so what we are going to have it, this one, please, you have to write it like this. These are the 11 points. You have to remember these 11 points. Okay. So this 11 points, what we are doing, first is the initial, we have to do initial assessment is what? We have to document full set of observation, whatever we have to give her the oxygenation, keep her warm, reduce risk of worsening of the crisis. Means we have to warm her. Okay. Now we will do start our management analgesia. The first one, after this one, first we assist her and then we start the analgesia. First, we have to know what is the score. She is having what score she is having it. We will go down. We will know what is the one. Okay, if she don't so much in a pain. So first one, we have to give her, we are talking about the gestational age. So diclofenac, we cannot give after 32, you know it. So first we can give this thing. It is written. If she is less than 30 weeks, we can give it TDS for 2 days. Otherwise, after 30 or 32 weeks, we don't give it. Okay. And then she can have a regular paracetamol, okay, IV or a PO, whatever she can take it if whatever's suitable for her. Then we have to give her the morphine. Morphine is the one subcutaneous or IV. If her booking weight is less than 50, we can give her 5 milligram. This is this morphine we cannot give without weight. Okay. So if less than 50, 5 milligram state. If she is more than 50, 10 milligram state, she can have a morphine. Okay. Because she is in a severe pain. This is called the painful crisis, acute sickle cell crisis. That's why we are giving the morphine. Fluid. Then fluid, we have to give her the fluid. Just we have to take the name. That's not the thing that we have to give, what we have to give. 500 ml for hourly warm. We have to give warm fluid with blood warmers. Okay. We are not going to give her the cold. Because if we will give her the cold, she is already in crisis and we will give her cold, she will be more in crisis. Then what we are going to do? We have to give her the oxygen, 96% oxygen, means full oxygen, 5 liter per minute we have to give. Then we have to give her heparin, low molecular weight heparin, as per protocol, whatever it is. Why we are giving it? Because she has a more risk. She is now in crisis. In crisis, she has a decreased movement of the blood. Okay, the flow blood will be decreased, so she can have a more risk of the thrombosis. So she has to need the heparin. Okay, then we will go for the investigation. What investigation we do? Blood investigation. We'll do this thing: full blood count, LHDs, okay, and LFT, UND. Then we will do the urine dipstick, okay, and the protein we have to check. Microbiological is very important because, see, maybe this thing she can have it, this crisis, because it can be a infection, MSU, throat swab, blood culture. We have to take from her that thing. Okay, then routine chest, if it is not performed, because the chest syndrome is maybe a problem of me, she is having an infection. Maybe that's what, maybe that's not the cause. Then we have to reassess her. We have to give her the pain within 30 minutes and repeat the analgesic dose if it is not resolved. Okay, and then we have to make her in observation. Observation, how frequent we have to do after 15 and 13 minutes, because she is on continuous observation. But see, there is a one thing is there. Okay, first we finish this one. Then maybe she needs the transfusion. Unless there is a clinical emergencies, all transfusion, which we have to discuss with the hematologist. Without hematologist, we cannot give her the blood. Okay. And then if needed, we will give it a hepatitis negative blood to her, RH, KL negative, RH and KL matched one, and cytomegalovirus virus negative. Now, what ongoing medication we will give her? Analgesia, regular analgesia, okay, PRN or whatever it, subcutaneous, IV or orally, whatever we can give to her this thing. Then morphine, we already do. what morphine we can give it. And we have to start her the folic acid with penicillin. If she is sensitive to penicillin, after test dose, we can make it now. The penicillin, erythromycin, we can give it. Okay, G. Then we have to screen for the infection. IV antibiotic we have to give her if she is febrile. Okay, we'll start it. Maybe we have to think maybe she is in sepsis. And then monitoring. Now we have to know about the monitoring. She can, because we are giving her opiates. So opiates, she can have a toxicity. So what we have to do, following require escalation of the hematologist on call. What we have, how we know? Opiate toxicity, how we know it? Maybe she has a low respiratory rate, conscious level will be decreased. Chest syndrome, she is hypoxia, showing the chest x-ray, shadowing will be there. Hepatic and splenic segmentations. We have to see these things and we have to check for the features of the preeclampsia. Then we will come for the baby. Baby, what we are going to do? Baby, we have to do the CTG monitoring. Okay, we have to check about the baby also. And then we have to also contact to the anesthetic. You see, there is a one thing difference here in our cases, and we have to check for the fetal movement. See, in the European side and outside the world, this RCUG side, fluid management has to be managed if there is an emergency. It has to be managed by the anesthetic. In our country, we don't do like this. We are not calling for the anesthetic until we will go for the OR for something. But outside where the fluid balance has to be managed by the this anesthetic. Okay, and when there is a OB labor ward prioritization, when there is a this thing at that time, there is also a anesthetic role is there when we will do labor ward prioritization. Okay, Ji. So what he is telling it that the sickle cell is life-limiting condition if there is a acute painful crisis or chest syndrome. Okay. What will do the immediate admission? We already know if she is in a agonizing pain, increased pallor, breathlessness, and pyrexia. These are the chest pain. These are the criteria he's showing that she needs the admission. Now we will go to the painful sickle cell crisis. Okay, so we already know, we done it. Now talking about the pain. Pain, he is telling it. See, pain, we have to have a pain threshold. Okay. For this pain, what we are going to do? If she is in a mild pain, if she is having a score 1, 2, 3, then we will just give her NSAID and paracetamol. But if she has a moderate pain means what? 4 to 6. This is score we will give. Paracetamol and or a morphine we have to give. But if she is enough severe pain, then she has to give her dimorphine. We can give it, okay? And nowadays there is a new thing they are giving. They can give this dimorphine and this morphine intranasal also, okay? So they have intranasals also until the IV line is not maintained if she is in ER in emergency. Okay, these are the one, intranasal dimorphine, a patient present in emergency. Okay, and then after the admission, so we have a two things admission with means maybe sometimes she needs the ventilation and she has to be admitted in HDU. So then this another thing we have to know, but this is the only just thing we have to know. Okay, so this we finish it. This is one thing we have. Then we have another complication, acute pain syndrome, acute chest syndrome, which we call it. Okay. So this one, acute chest syndrome. We finish it, acute sickle cell crisis. Now another complication is what? Acute chest syndrome. Anybody there, they can read it? I found it. Dr. Zainab, Yasmin, anybody wants to read? Dr. Zainab, can you read it if you like? Dr. Zainab or Dr. Safia, anybody wants to read? Dr. Ikra, anybody wants to read this one? Acute chest
Yes,
syndrome.
yes, doctor.
Okay,
Okay, I will read it.
okay, you are ready. I will be with you. If there is a
Yes.
explanation needed, I will tell it. Okay?
Okay, doctor. जी doctor.
आप अपना नाम
Okay,
बताइए.
management of
आप
I'm Dr. Zainab.
ओके, वो इसलिए कि क्योंकि आपका इसमें वो ये अभी जो आएगा ना जूम में, तो आपका फिर नाम वो है, तो फिर वो आ जाएगा तो अच्छा रहेगा। चलिए बोलिए डॉक्टर जैन, बोलिए।
जी डॉक्टर। मैनेजमेंट ऑफ acute chest syndrome. It affects the 10% of the women with sickle cell disease in the pregnancy. And how patient present, what are the signs? Signs, fever and or respiratory symptoms and new pulmonary infiltrates on the X-ray. And what investigation we will need? We will need chest X-ray CXR, full blood count, blood culture, sputum culture. Consider arterial blood gases in the adults with a low saturation as a severe hypoxia is a helpful determinant of the disease severity. Now consider the preeclampsia is a pulmonary embolism as a differential diagnosis if CXR, chest X-ray, and the chest examination are the normal. CTPA is a safe in the pregnancy. It should be discussed with the obstetrics and the hematologist. And antibiotics with the cover of atypical organisms should be used even if the blood cultures and the sputum cultures are the negative. And the management includes the pain relief, incentive spirometry, and the treatment of the bacterial and the viral infections. And consider the blood transfusion early in the hypoxic patients. A simple
हम्म। हेलो, हेलो, कैन यू हेयर मी?
early
हम्म, कहिए।
or a less severe disease. जी डॉक्टर।
हाँ, नेट में शायद हो रहा है प्रॉब्लम।
हेलो।
हेलो जी, आ रही है, आवाज आ रही है, कंटिन्यू कीजिए। कैन यू हेयर मी? आपको आवाज आ रही है?
एक्चुअली
आ रही है आपको आवाज? आ रही है आपको आवाज? डॉक्टर जैनब, आ रही है आपको आवाज?
जी जी डॉक्टर यस।
तो पढ़िए फिर,
शुड आई
कर
कंटिन्यू?
कर लीजिए। हाँ हाँ, कर लीजिए, क्योंकि ये तो अभी चला जाएगा, मुझसे हो जाएगा।
जी जी
कर-
डॉक्टर। Consider the blood transfusion early in the hypoxic patients. A simple top-up transfusion may be suffice in the early or a less severe disease, but the exchange necessary will the features of the
डॉक्टर
clinical severity or a lack
अली
of
सामा,
response.
डॉक्टर अली प्लीज कैन यू, ओके आई म्यूटेड, ओके चलिए चलिए कंटिन्यू कीजिए डॉक्टर जैनब, इसलिए आवाज
Okay.
प्रॉब्लम हो रही थी, कहिए।
Okay. A simple top-up transfusion may be suffice in the early or a less severe disease, but the exchange transfusion will be necessary if there are the features of clinical severity or a lack of response to the simple transfusion. And will involve the critical care team in the cases of severe clinical features are the signs of deterioration to consider the non-invasive and invasive ventilation and the transfer to the high dependency or intensive care unit ICU. Following an episode of the acute chest syndrome requiring a transfusion, women should be offered the regular transfusion for the rest of their pregnancy. And management should be the follow Thames Valley hemoglobinopathy guideline, acute chest syndrome management.
ये तो छोड़े डॉक्टर साहब, देखिए प्लीज इसमें सिर्फ देखिए ये जो दो जो है ना डिजीज, देखिए हमारे पाकिस्तान में अल्लाह तेरा शुक्र है अल्हम्दुलिल्लाह हमें ये फायदा होता है। देखिए मैं अपने मुल्क में हूँ तो ये फायदा, अपने घर आई हुई हूँ तो देखिए कितना फायदा है कि आपको अजान आ रही है, और वहां पे तो आपको माइक पे उस पे लगाना होता है, अपने टेलीफोन पे अजान के लिए लगाना होता है। अल्लाह तेरा शुक्र है कि हमें अपनी अजान की आवाज आ रही है, वहां तो सुनना नसीब नहीं होता। ओके जी, सॉरी, अब वो एकदम अजान की वजह से मैं बोल पड़ी। तो देखिए इसमें क्या होता है, देखिए हमारे पास दो चीजें होती हैं जब हम वो करते हैं ना, हमारे पास जो दो बहुत इंपॉर्टेंट जो सिकल सेल के लिए हमें दो चीजें आनी चाहिए, सिकल सेल क्राइसिस एंड एक्यूट चेस्ट सिंड्रोम। तो डॉक्टर साहब आपने याद कैसे करना है? देखिए अक्यूट चेस्ट सिंड्रोम में क्या होगा डॉक्टर साहब, आपने इसको ब्लड ट्रांसफ्यूजन देना है। ठीक है जी, ब्लड ट्रांसफ्यूजन होगा और इसमें इन्फेक्शन के भी चांस ज्यादा होते हैं, इस वजह से इसका एंटीबायोटिक कवर भी हो जाता है। ठीक है जी डॉक्टर साहब, इसमें ये होगा, थोड़ा सा याद करने के लिए बता रही हूँ मैं आपको। और फिर जब अगर आप उस पे जाते हैं अक्यूट सेल क्राइसिस में जा रहे हैं तो डॉक्टर साहब उसमें क्या होगा, उसमें ब्लड ट्रांसफ्यूजन की बात नहीं होगी। यहाँ ब्लड ट्रांसफ्यूजन था, वहां नहीं है। उसमें उसको पेन है, उसका पेन का स्कोर के थ्रेशोल्ड के हिसाब से आप उसको मॉर्फिन देंगे 30 मिनट के अंदर अंदर। तो डॉक्टर साहब ये डिफरेंस है, तो ये डिफरेंस हमें याद रखना है। ठीक है जी, याद क्या रखना, मतलब यही आपको एग्जाम में आप याद रख के रहेंगी तो उसी के बेसिस पे आप उसको पूरा मैनेज कर सकते हैं। देखिए वो पेन की ही प्रॉब्लम से ही आएगी वो उसके। अब आपको उसको डायग्नोज करना है कि उसका पेन कहाँ पे जा रहा है, इसको अक्यूट चेस्ट सिंड्रोम है या अक्यूट पेनफुल क्राइसिस है सिकल सेल का। तो दोनों का आपको डिफरेंस का याद करना है, डिफरेंस करना है। ठीक है जी डॉक्टर साहब, वो आपने कर लिया
जी जी डॉक्टर।
तो आपने पूरा कर लिया, पूरा स्टेशन आपका हो जाएगा, आराम से स्टेशन हो जाएगा। ये दोनों करने के लिए मैंने पूरी कोशिश तो की है कि ये जो है अभी इंशाल्लाह रब्बिल आलमीन ये जो है ना तीसरा वाला, ये अक्यूट स्ट्रोक वाला, ये डॉक्टर साहब इतना इंपॉर्टेंट नहीं है। इसको नहीं पूछते, इसको लिफ्ट नहीं कराते, बस वो इस दो को लिफ्ट कराते हैं एग्जाम वाले दिन जो होता है ना, बस इनको ये चाहिए। आपने ये बोलना ये वाला इसका अक्यूट पेन का एपिसोड का, ठीक है जी, और अक्यूट चेस्ट सिंड्रोम, बस इनको ये दो चाहिए और कुछ नहीं चाहिए। ठीक है, तो अब ये 5 मिनट में ये खत्म होने वाला है। ये क्या नाम है इसका, जूम। जूम तो खत्म हो जाता है ना 45 मिनट, आई थिंक सो। तो बस आपको इतना ही काफी है, तो कल इंशाल्लाह ताला हम एंटी डी कर लेंगे। ओके जी, किसी को कोई सवाल तो
जी
नहीं
जी डॉक्टर।
पूछना? नोबडी
डॉक्टर
वांट्स
एक क्वेश्चन है।
टू ये।
यस आई हैव क्वेश्चन। डॉक्टर अगर हमें एग्जामिनर जो है वो एग्जामिनेशन पूछता है, तो हमें जनरल फिजिकल एग्जामिनेशन में जैसे कि स्पेसिफिक मतलब रिलेवेंट एग्जामिनेशन, तो इसमें हमें लेग अल्सर्स कहनी होगी?
नहीं देखिए, आपने जाना क्या होता है, जो आप उसका पूरा एग्जामिनेशन कर रही होंगे ना डॉक्टर साहब जिस वक्त, तो उसने क्या कहना है, उसने आपको अगर वो देखिए डॉक्टर साहब एग्जामिनर पर होता है कि वो आपको कोई पर्टिकुलर एग्जामिनेशन का बोले या वो कहे कि भी पूरा एग्जामिनेशन करके बताओ, यही होगा ना दोनों चीजों में से। अगर उसने
जी
आपको फुल एग्जामिनेशन का है तो डॉक्टर साहब आपने लैग का जरूर बताना है कि लेग्स आर क्लियर, देर इज नो, ये होती है ना वेरिकोज वेन भी होती है, बाज दफा कोई अल्सर भी होता है, एडिमा भी होता है, लेग्स में होता है क्या है, यही चीजें होती है ना। तो
जी
वो तीन
डॉक्टर।
चार चीजें आपने उसको बतानी है। अगर उसने फुल एग्जामिनेशन आपसे कहा है और अगर उसने नहीं कहा है तो वेल एंड गुड, आपके तो मजे आ गए। ओके
ठीक
जी,
है डॉक्टर। जी जी डॉक्टर।
क्योंकि
थैंक यू।
ये उसके ऊपर एग्जामिनर के ऊपर होता है, बाज दफा वो आपसे क्या आस्क करें, बाज दफा तो वो जान छोड़ देते हैं कि नहीं जी पर एब्डोमेन ही बता दो। और डॉक्टर साहब पर एब्डोमेन एग्जामिनेशन जो होता है ना वही सब में खौफनाक होता है। वो उसमें क्या होता है डॉक्टर साहब, उसका सुपरफिशियल एग्जामिनेशन होता है, डीप एग्जामिनेशन होता है, और फिर उसको इंस्पेक्शन, पल्पेशन, परकशन, ऑस्कल्टेशन, ये उसमें डिवाइड हो जाता है ना। तो वो हम कैसे
जी जी।
करेंगे, वो इम्पोर्टेंट होता है इसके लिए। अगर उसने पूछा, एग्जामिनर की मर्जी पे है, अगर टाइम मिला